So our next speaker is Dr. Mark Stable. He is a professor in wealth inequality and professor of economics and academic director at INSEAD France. He's going to talk about dispatches from the north, the good and the bad of Canadian healthcare. So allow me to welcome him, please. Thank you.
Okay. Bonjour, Madame et Messieurs. 3 years in France, that's all I have for you. Nothing more on the French. Instead, I'm going to talk to you about Canada. And let me thank the Baker Institute for having me. It's really an honor to be here. And also let me thank my friend, Dr. Danielle Martin, who provided me with some of the slides that she used in a presentation to Bernie Sanders talking about Medicare for All. So some of those were ones that we also used there. So I'm going to tell you a little bit about how the Canadian system works, and then I'm going to get into what I think of as the good and the bad, and I'll add the ugly of Canadian healthcare, what I think has worked well and what I think is not working so well, and hopefully with some implications for the US. So here we go. So let's start. What's Canadian Medicare? So first of all, when we say Medicare, we mean Canadian Medicare. Every time I say Medicare, I'm going to be referring to Canadian Medicare, not US Medicare. We share the name, but that's about where it ends. So the first thing is that there isn't a system called Canadian Medicare, even though Canadians do say that. There are 13 systems. And that's because most of the systems are run at the provincial or state level and not at the national level. There is a small national healthcare program, but it's really for people in the armed services, for First Nations people, and for refugee claimants, and a few other people that are not permanent residents of one of the provinces of Canada. The rest of it is run by the provinces. And as you can see, what it's supposed to do is provide an interlocking system that gives you access to medically necessary hospital and physician services on a prepaid basis. Okay, the federal government pays some of the cost. It started at about 50% of the cost. Today, it's dropped below about 25% of the cost. The rest is paid for by the provinces, raised through taxes. However, in order to receive that 25%, what all of the provinces have to agree to is to follow something that we call the Canada Health Act, and that has 5 principles, and you can see them here. Universality, everybody is in, nobody's out. Accessibility, there should be no barriers to care, no user fees at all. I would note that is specific to the next item, which is comprehensiveness, which is doctors and hospitals are covered. That's a strange definition of comprehensive, but that's the one that we use. Portability, i.e. it's supposed to be the case if you change provinces or visit a province, your health care comes with you. You don't have to re-qualify from province to province. And public administration, the system is supposed to be run publicly, and they are publicly accountable. So these are the 5 principles. If you do this, you get your federal funding. The rest comes from the tax base of the provinces. Much like the states, they have their own income taxes, if they wish, they all do, their own sales taxes, etc., to raise the money they need. So what do those provinces do? Here's our map of Canada. They are, in each province, it's a single-payer system. So within the province, there is only one system. Everybody is part of it. To answer a question that came up in Anita's wonderful talk that may come up here, no, you cannot go and buy private insurance on top of the Canadian healthcare system. You are in that system. We have a great country to the south of us that provides care if you want to go and get some quickly, but no, you can't do it there. Provinces have some flexibility in deciding what's included in the basket of services. Right? So in terms of who decides what it is that these plans cover, that's the provinces, except for doctors and hospital services. But even then, as new things come on board, provinces have a lot of say as to whether they're going to cover it or not. So what does medically necessary mean? I don't really know, and nor does anybody in Canada. But here's how we think about it, right? It's at the discretion of the provinces. Generally, hospitals and physicians. New technology is assessed for safety by the federal government, but then the provinces have to figure out whether they're going to pay for it. Drugs, dentists, eyes, eye care, home care are all not fully covered in Canadian Medicare, although provinces will choose to cover some populations and some of the costs, but that's up to them, and that is quite different from province to province. In general, that's poorly covered. Okay. What's public and what's private? That's actually a bit complicated. And to think about this, let me first separate for you private financing and private delivery. I'm going to spend most of the time talking about private financing, how we pay for it, or public financing, how we pay for it publicly and privately. But just to talk quickly about delivery, let's just say, I'll break it down here. Doctors are for-profit private, okay? Much like the UK, they're their own entrepreneurs. They build a public system, but they are for-profit, they're making money, and they are private. Hospitals are mostly not-for-profit, although they have considerable oversight by government. Nursing homes are a mix, some for-profit, some not-for-profit, some, not many, public. Most of them do receive some, but not much public money. Nurses are employees of the hospitals, okay? Pharmacists are for-profit, and the drug companies, of course, are for-profit. All right. So how do you sum all that up to Canadian Medicare? I wouldn't call it socialized medicine, although some have. There's a lot of private for-profit going on. This is Ronald Reagan before he got into politics, speaking out against socialized medicine. But it is slightly different than what we normally think of when I think of socialized. There's a lot of for-profit going on in Canada. Okay. How much are we spending and how are we doing? Well, here's what's been happening since about 1975. I'll tell you a bit later, but in fact, Medicare, as we know it in Canada, is only since about 1975. And costs have been going up, as they have been everywhere else. There was a time in the early 1990s when the IMF came out and said if Canada doesn't get its spending under control, it's going to turn into a third world nation. And for a little bit, as you can see in the early 90s, we cut spending back and the rate of growth slowed down. And a whole bunch of people wrote cases of how did Canada do this miraculous thing. In actual fact, we did very little. We did big cuts, but then we've made up for it, more than made up for it, since then, by spending more and more. So in fact, if you were to draw a straight line from before the 90s to now, those cuts have more than been undone by cost growth since that time. Okay? About 6,600 Canadian per person, about 11.5% of GDP. As a percentage of GDP, it's also been going up. This graph starts at 5 or 6, not 0, so that, it's a little bit less steep than it might first appear, but still we're seeing a slow but steady increase as a share of GDP. After the financial crisis, we saw a dip that we saw in many countries, but we're predicting that that's now on the rise again. Okay? The public-private mix. Canadians think they have a fully public system, but of course they do not, and no system is either fully public or private. Ours is about 70-30, and that 70 public, 30 private, and that has been fairly constant over the last several decades. As you can see, going back, well, I'll show you only from 2000, but it's been fairly constant since the beginning. That 70-30 split is pretty stable in Canadian healthcare. How do we spend the money? Hospitals are still the biggest item. That's this green piece, or whatever that color is there, the solid piece. The next two big ones, and they are now in a place where they go back and forth from one year to the next as the next biggest one, are doctors and drugs. All right, if you add up drugs that are prescribed and drugs that are not prescribed, they are bigger than doctors. And then we have a bunch of everything else, other types of professionals, other types of institutions. Perhaps, since it's often noted, I will point out that there is a sliver there for administration. It's 2.5%. That's I think, one of the successful pieces of Canadian Medicare is that the administrative costs are actually quite low as a share. Now, that's how we spend the money, but how that breaks down in terms of what's paid for publicly and what's paid for privately differs quite a bit. And what you can see here, that's what I hope you will see, is that when it comes to hospitals or physicians, almost all of it is public, right? Those are the green bars at the beginning. When it comes to drugs or other professionals, and I don't have dental up here, it's in the other category, that flips. And most of it is private, and very little of it is public. Okay, so very much depends on what it is that's being paid for, how that 70-30 split plays out. In terms of cost growth in Canada, like many, many other places, costs have grown faster than GDP, right? There was an exception to that during the financial crisis, but in general, costs have grown faster than GDP, real cost growth each year. Unlike the UK, I found it very interesting that they've been taking the money from defense. We've been taking the money from education and from social programs. The healthcare machine has to get fed. There's limited appetite for tax increases, and so if you do a study of how provinces have dealt with that, they either borrow more or they claim money back from other budgets, and those budgets, because provinces don't do defense, have generally been other social type spending like education and social programs. Okay, so some similarities, but then some big differences from the UK. That cost growth, however, is not out of line with what's been happening. There are very few countries that have not had costs grow faster than GDP. And so every country in one way or another, as Anita said, I thought quite accurately, has been dealing with this in some way by either raising taxes, borrowing from other programs, or shifting costs to people instead of government, right? We do it one way or we do it the other. Okay. How comprehensive is the public funding? Here I'm comparing my old home to my new one, France on the bottom. And again, what you see here is how comprehensive parts are. Hospitals and physicians are very comprehensive, and how not comprehensive other parts are, like drugs and dental services, and I'll come back to that a few more times, actually, in the course of this. I thought you were going to show the Commonwealth rankings. You did not. The Commonwealth Fund has been ranking healthcare systems for a little bit of time now. The first time it came out, I had the pleasure of serving in government while these rankings were released, and at that time, the US was last. It's still last, and it has been, I think, every year the Commonwealth rankings have come out. But Canada was second last. And since I was the person who was doing a lot of health policy stuff, the advisors looked to me and said, you go tell the Premier what the rankings say. You're the health policy person. So I went in there and I said, you know, Premier, the rankings have come out. Canada has not done well. We are one place above the United States, but we're second last. And he looked at me and said, that's not a problem. The data must be wrong. Right? And that is actually not an atypical approach in Canada to dealing with some of the facts that around rankings that show how we do and don't do. In fact, over time, it's interesting in these rankings, over time, actually, there's been a lot of moving around of countries that have done better or worse. Canada and the US are not among those countries that have moved around a lot. We have stayed towards the bottom of this small list. Okay. So, when the Canadian Broadcasting Company, our BBC, our public broadcaster, did a poll of Canadians at our 150th, what makes you most proud to be Canadian? I think you can tell where this is going. We had 3 items, top 3, here they were: Canadian Medicare, peacekeeping, and the Charter of Rights and Freedoms. Okay? Canadian Medicare, peacekeeping, and the Charter of Rights and Freedoms. I found this baffling, because if you've spent any time outside of Canada, particularly in countries around Europe where I now live, you will know that this is not at all unique. But what we need to understand about the way that Canada defines itself, its exceptionalism is in reference to one place, and that's you guys. So Canadians, when they think about what makes Canada exceptional, like to use a single reference point, that's you. These are areas that we felt we were doing better. And I think that actually goes a long way to explaining where these polls come from. All right. It is interesting to note that prior to 1970, the two systems across the two countries looked extremely similar. Heavily employer-based for insurance. Blue Cross, Blue Shield was very active in both countries. That this has been something that has changed dramatically in just my lifetime. I know I'm getting old, so that's becoming a longer period of time, but it wasn't always as it is, which is interesting when you think about where you are today. Okay, let me get into the good, the bad, and the ugly of Canadian healthcare. And to do that, let me provide a framework that I want to try and use to help thinking about what a system has to do to finance a healthcare system. And I'll put out 4 items that I think it needs to do. Right? It needs to raise revenues, has to pay for it. It needs to pool risk. Some people are healthy, some people are sick. We want to cover people, we have to pool. Insurance has to do that. Whatever else insurance does, it has to pool risk. All right? We want to purchase services, and we have to figure out what to cover. I've used this framework, as have others, in the past. I want to use it today to help guide our thinking about what's worked well in financing healthcare in Canada and what is not working so well. So, the good. What have we done well? I would put the first 2 as big successes in Canada. Not unique to Canada, but certainly big successes. The first is raising revenue. And if you're interested in having a somewhat stable, usually growing, progressive source of financing, I think what we now know, this is true in the UK, this is true elsewhere, is that the tax system provides our best shot at that. It's not the only way to do it. That's not the way they do it in France. That's not the way they do it in a number of other places. But it does do a pretty good job of raising revenue for the system that is efficient, uses mechanisms that are already out there, and is also progressive. So that's success. And it's relatively efficient administratively. I showed you 2.5% of the system is spent on administrative costs. Most of the estimates I've seen comparing US and Canada, administrative costs suggest that ours are less than half per capita of the US. And I think that's also a success story there. The other big success, I think, is the pooling of risk. How have we covered people? And here, the universality of the system has, as in the UK, done a great job of eliminating much of the financial risk from individuals, right? It would be almost unheard of in Canada to go bankrupt because of healthcare costs. It is very rare, as in the UK, that you would spend a huge proportion of your budget, anywhere near 10%. That would be very difficult, again, to do for various reasons in Canada, although some people who need some specific drugs might get there. There we've also done well, and we have focused, and I was very interested to hear Anita's comments here too, we have focused, you know, the US, of which I was trained and am still a part of, health economics literature, focuses on two big issues. Adverse selection, right? How do we make sure that people all have insurance and they're not selecting into insurance companies and vice versa? And moral hazard. What happens when we provide healthcare at no cost? Are they going to use lots of costs they don't need? Right? And I would say there's tons of literature on both those things, and you need to make a decision on whether you come down as being someone who thinks moral hazard is the bigger problem or adverse selection is the bigger problem. In my opinion, adverse selection is by far the bigger problem. By far the bigger problem. And here, Canada has solved it. Everybody is in. Everybody's covered. Same with the NHS. Everybody's in. Everybody's covered. This, I think, has been, there's other ways to do it. Right? You can pool risk in a number of ways. When I talk to my students at INSEAD about Obamacare, right, I break it down. You have to pool risk, you have to pay, you have to regulate. And of course, you can do it through mandates, you can do it through taxation or subsidies, and you can regulate or create a market. This Obamacare tried to do all of this. But the way that Canada does it and the way that the NHS does it, I think is if you're worried about adverse selection, very simple. There's one pool, you're in. Okay? The question is, what's happened on the moral hazard side? And I would make 2 points. The first is, I think no matter what's happening on the moral hazard side, the adverse selection is more important. I'll add to that it was very interesting to hear Anita say that in the UK, for whatever reason, people are reluctant to go to the doctor, even though it's free, right? Suggesting that you make it free and they haven't had an explosion of moral hazard. I wouldn't go that far. I do think that prices matter. I firmly do believe that prices matter. I just think that of the problems you need to try and solve, the bigger one is getting people insured. And once you solve that problem, the last point I'd make here is that it in no way precludes, once you have people insured, having cost sharing on either the part of patients or the part of physicians, demand side or supply side, right? It doesn't have to be an either or. It's a matter of focus more than anything else, and here I think the adverse selection focus has been part of the success story. Okay, where have we instead stumbled? And on the other two financing pillars, I think Canada has some interesting lessons to teach us about what doesn't work. All right, I flipped them. This used to be 3 and 4 in the other direction, but I want to flip it this way, which is first talk about making coverage decisions. And here, I think, again, we need a framework to think about how we do this, to see what Canada has done and how it is not working well, and then I'll come back to purchasing services. So how do we think about what to fund? And I'd offer 4 categories that I use to think about this. And let me say before you say, but wait, we see this, we see that, we see the other. Many countries have all 4 of these in play. But here are 4 ways to think about this. 1, you can have broad public coverage, and then you can allow for a parallel private system that runs alongside it if people want to buy supplemental stuff. And I would put out the UK as an example of that. You can have a co-payment system where the coverage is, again, very broad, but in every case, people have to pay some of the cost. They never cover 100%, and you have to pay some of the cost. My new home is very much like that. Every time I go to the doctor, I pay 25 to 50% of the cost, but there isn't anything I can do where the government doesn't also pay some of the cost. All right? You could do the group system, and I'll put the US in this category. I understand the US has many, many systems, but the group system is we're going to provide extensive coverage for some and less coverage or no coverage for others. So, you cover the elderly, you cover low-income populations publicly, but then you leave other groups on their own to buy private. That would be number 3. And the fourth is the Canadian one, this sectoral system, which is we're going to be very good at covering some parts of healthcare, doctors and healthcare services, and we're not going to do as much in other parts of healthcare. Okay? That's the framework. Once you have this kind of framework for public, the private side also falls out. And let me suggest this, again, this was borrowed from colleagues of mine in LSE, and what happens on the private side very much is going to reflect what's happening on the public side of what you decide to cover. And so you have these 4 categories of private that mirror the decisions made on the public side, right? So again, the US or Germany will be an example of substitutive care, right, where you have a public system, but you can opt right out of that, or you might be forced right out of that, and have a comprehensive private system instead. And you're choosing to either use the private system, or you're eligible for, or choose to use the public system. You could have complementary services. This is the Canadian one, where if you're not going to cover some things publicly, the private insurance market will step in to provide insurance for those things that we have not provided publicly. Okay? You can have complementary user charges. That's the French one, where the system provides some things publicly, or everything publicly, but never pays the full cost, and then you can buy insurance to top up that cost. And then you can have a supplementary one, which I think of as the UK one, which is everything is publicly covered, but if you want, you can go beyond that. You're not opting out, you're still in the public system, but you can get supplemental private. Okay, so with that, we fall into the second one, and this is the bad, in my view, all right? And here's why I think that. Healthcare delivery has changed incredibly rapidly over the last few decades. And it would be, I think, crazy to think that it won't continue to do so. The way we provide care, I don't know how we're going to provide care 30 years from now, but I can pretty much guarantee you that it won't be exactly the same way that we provided care 30 years ago. It changes, right? And it's going to. Healthcare needs, they evolve. We don't have exactly the same healthcare needs, but the needs evolve much more slowly. If you take the last 50 years and look at the diseases that we are trying to tackle, yes, some we've done better, some we've done worse, a few we've totally gotten rid of, but the evolution there is much more slowly than the delivery options and the way we actually do it. So, if that's what we know, it would be a mistake to plan your system around the delivery and not the needs, because the delivery is going to change. And the case in point in Canada is around prescription drugs. It's not unique to prescription drugs, but it is the most obvious example. When we planned the Canadian system, drugs were not a big part of healthcare delivery, and so we didn't include them. And we got stuck in the 1970s version of healthcare delivery, and we're still struggling to provide coverage for prescription drug. This is what actually has happened to spending. You see that hospital costs, while still the biggest, have come down. Less stuff gets done on an inpatient basis. And drug costs have gone up. I haven't even shown other things here that they might not exist yet, or they're not big enough yet to be the driving force, but they too will start to change, and perhaps we'll see less and less inpatient. Perhaps we'll see less and less need for a doctor. It'll be replaced with an app. I don't know. But what I do know is that things will change. So how does this coverage of drugs in particular for Canada compare? And you can see that we are, relative to our peers, sorry about the US being below, but relative to our peers, we are doing worse on this. But this is by passive design, right? It's not that, it's explicitly by exclusion that we didn't cover prescription drugs, and we have now been struggling to deal with that ever since, because we designed a system around medically necessary doctors and hospital services. What happens when you don't have coverage? Well, you don't have drug coverage. Either you can't afford the meds, so you don't take your medication because you can't afford it, or I also have evidence that suggests that you don't even bother going to the doctor because for so many things you know that what the doctor is going to do is prescribe for you. If you have no intention of fulfilling that prescription because you can't afford it, why waste your time going in the first place? Okay. So that's what's happened with prescription drugs in Canada. And it's going to keep going, right? Hospitals are still growing, but they're growing much slower than drugs. It's going to keep happening. So what is Canada doing about this? In fact, my friend Dr. Danielle Martin, who lent me some of these slides, is working around the clock to try and get Canada to include drugs in medically necessary and to have a system of programs that will cover drugs. And this is good. I think it is a good idea to try and expand drug coverage so that people who don't have access to insurance can get it. However, let's be honest, we are scrambling to solve yesterday's problem. When we finally get this done, if we finally get this done, and by the way, the Canadian Minister of Finance, who happens to be a grad of INSEAD, so he came by, we were talking about this, he's scratching his head saying, how can we possibly afford this? Even if we do manage to get it done, it's yesterday's problem, it's a symptom, it's not the real problem, and we'll begin again with the next technology that we haven't covered in our sectoral system. Okay, so that's the good and the bad. Let's get to the ugly. In fact, I do not think it will be the sectoral nature, the lack of drug coverage, and so on, that will sink Canadian Medicare. And the reason for that is a simple political one. Most Canadians, the vast majority of Canadians who can afford it, have gone out and solved that problem by buying private drug coverage, and it's good. They have good private drug coverage. Much like here, the vast majority of Americans have good health insurance coverage, and so whenever you get into the business of trying to figure out how it is you're going to insure everybody else, you have to deal with the fact that people don't want something worse than what they already have. Right? And that's true here too. So for the average Canadian, for health policy people, prescription drugs are all they're thinking about these days. But for the average Canadian, they really don't think about this. They get drug coverage through their job. It's good. And so that's not their problem. Their problem, which is why I call it the ugly, because I think it has much higher probability of sinking us, is that our wait times are bad. And some of those wait times are bad, clinically bad, and need to be fixed. And some of those wait times are not clinically bad, but policymakers have time, and doctors and health policy people have time and time again failed to understand that even if it's not going to kill you, people do not like to wait when they have to have a healthcare problem fixed. And so it's this problem that instead reduces support for the system. So we have a bunch of benchmarks. I have them somewhere. They're not up here. But what this graph shows you instead is how we're doing relative to some of the benchmarks we've set. And it's pretty much true, the top line, which is radiation therapy, that when you have something that's very severe, we're doing close to 100% of benchmark. Now, we may question if the benchmark is right, but it's scientifically determined by panels of doctors. Okay? And we do reasonably well. Where we do less well, and in some cases where we're doing worse than we used to do since we started to measure, which is not that long ago, right, is on things like cataract or on hip and knees. And these are the ones that are going to really piss people off. And in fact, you're seeing these court cases come up in Canada saying the Canadian system is denying me the right to care. It's supposed to be a right. I don't have it. I need to have my eyes done. I need to have my knee done. I need to have my hips done. And these are mainly old people who have lots of time to complain, who have lots of political power, and frankly also have a lot of money because that generation, if it needs to be said, has done relatively well. And these people are fed up with waiting, and they're going to try and do something about it. It's not going to kill them, but it's going to maybe do more damage to Canadian Medicare. Okay, what's happening to changes in volumes? In fact, we see exactly that in fact, we're doing more, but wait times are not necessarily improving. There's more need. People are aging. And so even though we're doing more on the volume side, that's the clear bar, in fact, the wait time sometimes is getting worse. Okay. And when you compare us to the rest of the world, once again, we see that, in fact, we're not complaining for nothing. That, in fact, we are doing worse. This is same or next day appointment, compared to a selection of North American and European and Australia peers, and we're at the bottom, right? It's better to be higher, and we're the lowest in terms of the percent getting same or next day appointment, and it varies across. So the blue is the variation within Canada, and this part over here is the variation between Canada and the rest of the comparators. Same is true with emergency rooms. Here, higher is worse, because it's asking how long do you wait in the emergency room. And again, Canadians wait longer. We're patient, but that patience is running out. Right? I think our Prime Minister might have said that with relation to renegotiating NAFTA with your president, but I'm not sure. If I'm quoting him, I apologize. But you can see that we tend to wait longer than our peers, and again, there's a lot of variation within the country. And what we know is that these waits undermine support for the system. What this shows you, it's a slide I borrowed from a political science colleague of mine, that over time we've been measuring how many people think we need to rebuild the system and how many people think we need to have only minor changes, and this is extremely correlated with that issue, wait times. Right? The longer the wait times are, the more people feel we need to completely destroy Medicare and rebuild. Everything else, minor changes. And so that's the one that I think has the biggest possibility of wrecking the good. Okay, I want to show you one other thing, which I know for some of you will appear minorly second order, but since I now hold a chair in inequality, I feel obligated to point this out. And that is the relationship between changes in income inequality and support for these kinds of public programs. Okay? The picture in Canada looks almost exactly the same as the picture in the United States. And this picture is showing you the income share of the top 1% of earners in the US. You've probably seen something like it before, right? It shows that from the end of the war to the late 1970s, the share of the top 1% as a measure of income inequality, you can measure it other ways, but this is one way, has been flat. And then starting in the late 70s, early 80s, it's been rising. It also shows, if you're interested, that the flat period is actually not the normal. It was historically not normal, that prior to, going back to the 20s, and thanks to one of my colleagues in France, Thomas Piketty, you can go all the way back to year zero, and you can see that, in fact, inequality was always high, it's come down, and now it's going up. My question then is, with this rise of income inequality, are we worried about the effects on our public systems? And we have reason to. So here's why I think it's a problem. The basic intuition is that all of these public programs, Canadian Medicare, the NHS, Medicare for All, if you want to think about it here, rely on trying to find something that works for many. Getting everybody in, Social Security, they all rely on that. Can we get something that works for many? And when you have a part of the population, the wealthiest part of the population, that begins to pull away from everybody else, the challenge of finding something that works for them becomes increasingly difficult. They don't want to be part of this. They want something more, better, etc. And, this is, if you like, pictures instead of words. As that distribution shifts, the attempt to satisfy the middle increasingly does not look attractive to the top 1%. The kind of Medicare that we can afford to provide for everybody in Canada is not attractive to the very rich. The kind of pensions we can afford to provide to everybody are not attractive. And so they begin to look for alternatives. And let me say that I've tackled this in two ways, on the demand side and the supply side, and I will be brief. But what you see over time is that the amount that the top spends, the top of the income distribution always spends more on healthcare. They're wealthier, and so they spend more. But the gap between them and everybody else is growing. They're increasingly turning away from the public system and spending more and more privately. Some of them are coming down here for care. Some of them are going to India for care. Some of them are finding other ways to get that done, but they're not using our system anymore, or they are using our system, but in an unfortunate way. The way they're doing it, and I don't have a good graph. I know this is totally not informative, but I'll just tell you what it says. The way they're doing it is they are convincing, through their demand, doctors and clinics to opt out of the public system. In Canada, you can't operate in both. So instead, what they've done is, as you can see that the demand is there, we have doctors who are saying, we're going to just not be part of the Canadian healthcare system anymore. We're going to operate privately on the side, and we will treat exclusively these patients in the top 1% who've chosen to do that. All right? As inequality becomes worse, the fear is that will become worse and worse, and eventually we will lose support for the universality that we have. Okay, so to recap, more demand, more supply, and as this happens, as we see more and more inequality, we might want to worry that of the good, of the progressivity, of the universality that Canada has seen through the healthcare system, we are going to start to undermine that, and we may lose it. All right, to sum up, what does all this have to teach, in my view, humbly, I think, the US, I hope? The first, so I have four, there might be others. The first is the importance of universality. And here I think, I've said it several times, I think the adverse selection problem, getting people insured, is the more important thing to tackle than the moral hazard problem. I have many colleagues who disagree with me, maybe some of them will say that today, but in my view this is important and is a lesson that Canada can offer the United States. The second is the trouble you're going to get yourself into, not that you're doing this, but the trouble you can get yourself into if you focus on the type of care instead of underlying healthcare problems. Focus too much on, do I have my doctor paid for, or do I have my drugs paid for, and you will miss the underlying healthcare problems which may be delivered in a different way and may change over time. Canada has suffered from that. The third is that we can get very detailed clinical information about optimal wait times, but they're not the same as individual wait times. Optimal wait times are a clinical definition of what we should try to do that maximizes health. Unfortunately, that's not the way people think, right? People respond to their own situation, their own nervousness. If they think they might have a problem and they can't get an MRI, even if an MRI is not the right thing, they start to reduce their support for the system, look for private alternatives, because their perception of wait time is different from the clinical perception of wait time, and that undermines confidence. And the fourth, and this comes both from the beginning and the end of the talk, is how social programs can actually change social cohesion for the better. Right? We've seen that, how country, the NHS, we saw it an hour and a half ago, and we see it here too, has come around, coalesced around these type of social programs and found unity there, but also how inequality can begin to pull that cohesion apart. And I think that is another lesson that I would humbly offer to you as you think about what we can learn from Canada. And I will stop there. Thank you very much. I think some microphones are coming around.
Hi, thank you for.
Hi, see you.
Thank you for a nice talk. So wait time seems to be a major problem in Canada. What do you think is the reason behind the big wait times? And this may or may not be related, but I wanted to ask a question about work satisfaction among health providers in the US, in Canada. Mm-hmm. So a while back it was a news that doctors actually went on strike to get paid less so that they could hire more nurses and pay them well. And I just wanted to know if there was an update to that.
Yeah.
So, thanks.
Okay, so on the first question, what is the problem with wait times? I think there are three different problems with wait times. The first is a coordination issue, right? When we let individual hospitals or even doctors within hospitals manage their own wait times, we have sometimes excess capacity one place and excess demand another place, and we haven't matched that properly. That appears to be a problem in Canada. right? That as we start to get around thinking about a more universal wait time instead of the wait time for a particular hospital or surgeon, we can do better. The second is a funding issue. It seems clear that, and not just in Canada but elsewhere, that every system rations. We've heard this already. Some systems ration by price, some systems ration by wait times. The less funding there is, the less funding grows in times of recession, in times of restraint. Wait times suffer, and we are seeing some of that through financial crises and et cetera, that has made wait times worse. When we spend more, that problem declines, right? That's point two. Point three, which completely undermines point two, right, but my colleagues would be angry with me if I didn't mention it, is that there actually is a bunch of stuff that people are getting and doing that should not be done. And part of the wait, and my doctor colleagues in Canada will continually tell me that the wait times for MRIs would be much lower if we just used them the right way. Right? Just as an anecdote, a couple of years ago I smashed my head and I gave myself a concussion and it was going badly. I was having trouble reading, my head was hurting all the time, and I was calling colleagues in the US and they said, "Have you gone for an MRI?" I said, "No, I haven't." And they said, "Well, you need to go for it." I heard this 5 or 6 times. So I finally went back to see my doctor and I said, this was 3 or 4 weeks after my concussion, and I said, "Should I be getting an MRI? Do I have like some serious internal bleeding?" And he said, "Mark, if you had serious internal bleeding, you'd be sitting here with water dribbling out of your mouth, not able to argue with me about whether you need an MRI. You clearly do not have that problem, and if I sent you for an MRI, it would be a complete waste of time." Right? Maybe he was right, maybe he was wrong. I recovered, but I think. But the point being that along with having to spend more sometimes, we have to do less other times. And the coordination problem is the third. To your other question about doctors going on strike for less pay, if only that was the majority of doctors in Canada. It is not. There are a group of doctors led by the colleague that I called out at the beginning, Dr. Danielle Martin, who have founded an organization called Doctors for Medicare, who are pushing back on what has been an extraordinary amount of salary gain for physicians over the last while in Canada. They're doing extremely well. We used to worry about them leaving for the United States. That is no longer a problem, for a variety of reasons, but one of the reasons is that there's a lot of money to be had. And there is a bit of a push to try and get that under control, but that is a complex negotiation. Physician salaries are set, not salaries, they're not paid on salary. Physician prices are set as a negotiation between the provinces and the medical associations in those provinces. And those medical associations have to deal with their own internal dynamics, because sometimes the pie grows and sometimes the pie has to be redistributed. And there have been some big winners and some losers, and so that is complicated. And so the update for you is, I don't think that we are suffering from strikes for people trying to lower their salary, although it was a nice gesture. Yeah.
Good morning. Thank you for your thoughtful comments. Question around, one of the things that I thought was particularly interesting is how much the provinces are paying for that amount of care. And so thinking about it in terms of them having their own population to manage, what are the kind of, how similar are the outcomes amongst the provinces? And is that, are there incentives for the provinces to manage those, to decrease costs? And kind of your comments between the costs and the outcomes and the differences there.
Yeah, that's a good question. The provinces are not that similar. Very much like here, there are provinces that are wealthy and provinces that are not. And the provinces that are wealthy have a bigger tax base, and they put more money into healthcare, and they are able to do more with that money. The federal government, through a different program, which we call equalization, very controversial program, tries to, not only around healthcare, but around everything, transfer money from the have provinces to the have-not provinces, from the wealthier provinces to the less wealthy provinces. But this sets up some dynamics, as you might imagine, right, where you have a governor, we call them premiers in the provinces, campaigning, saying, I'm going to stop this practice of taking the money from our people away and giving it to other people. Right? We have needs here, we have our own needs here, we need to manage it, and so we are not doing as good a job if the definition of good is to have similar outcomes across the country, we're not doing a fantastic job of that. There are also populations, and with particular note First Nations populations, where the health outcomes are atrocious. And we are very guilty of having done a horrible job of addressing the particular needs of that population. And it's a real source of inequality that has not been solved by any means. So lots of differences. Some programs try and reduce those differences, but big differences remain.
Interestingly enough, your last set of comments sounds just like the public education financing system in the state of Texas. Take from the rich, give to the poor. The rich don't want to give, and the poor want more. But my question goes back to your very first comment, actually, where you said there is no private insurance available in Canada. Mm-hmm. And then you proceeded to outline all the private insurances that were available.
Yeah.
Would Canada be better off in taking a aggregated approach to health insurance rather than the rich getting better drugs than the poor because they can afford insurance, and the inequality might go away?
Mm-hmm. So that's a explosive question, actually. But let me try. Are we being filmed? So first of all, let me clarify what I meant by what seems like two comments that don't go very well together. The first is what Canadians cannot do is get insurance for a service through a private insurance for a service that is covered publicly. Right? So if you want to go and get your MRI privately, or your knee fixed privately, or your cataract done privately, you cannot go out. There's no market for insurance for that. Okay? For a variety of reasons. And so to do that, you either have to go to the US and get it done, lots of people do, or you have to go to one of these emerging clinics that have completely opted out and are somewhat illegal in a sense of the whole system in Canada and get it done there. They're not exactly illegal, but that's a more complicated legal issue. What there is insurance for, obviously, as I said there was, is for the things that the system has chosen not to cover. So for dental and drugs and eyes, et cetera, that the public system says we don't do this, then it's fine to go out and get private insurance for that. And most Canadians get it through their job, like most Americans get health insurance. Not all, but more than 50% for sure, more than 60%. And so then the question is that an efficient way to do it? Or should there be some more comprehensive way to do it? It is clear that if you wanted to worry about total costs of insuring people for those services, the more efficient way, from a cost perspective, to do it would be to shift it all to the public system. The problem is that there will be losers when you do that, because the public system will not provide, it's very unlikely, that the public system will provide the same quality of coverage that the very best private plans provide. There's another problem, which is that people are now paying for those private plans either through their job, in which they don't really understand fully that they're paying for them, or out of pocket. But to pay for the public system, they would have to have their taxes increased. And just like in every other country, there is a disconnect between paying more tax and getting more. People want more, but they don't trust the government to take that money to give them the more, right? And maybe they don't actually want it to be redistributed in the way that governments do. And so there's a blockade there as well. So from an efficiency point of view, I think the answer is yes. From a practical point of view, I think the answer is it's very challenging, because people don't want their taxes to go up and they don't want to lose what they have. And that's the thing we're trying to overcome, without much luck.
Thank you. Although rising average drug prices are a problem everywhere, one of the more extraordinary problems are some of the newer drugs, the immune modulators, checkpoint inhibitors, et cetera, that are extraordinarily expensive, hundreds of thousands of dollars a year. Yeah. How are those just not covered? Are those patients just not receiving them, since there's very little drug coverage in Canada? What happens to patients that have a cancer and that needs those drugs? So
cancer drugs that are delivered in the hospital are publicly funded, right? So if you're getting the drug in the hospital as part of treatment, or in a clinic attached to the hospital. It is publicly funded. However, controversially, Canada has made, well, different provinces have made different decisions around this drug being too expensive, not worth it, and actually other provinces making the opposite decision. It's a source of some tension within Canada. Like in the UK, we have an evaluation of these things, and when it's felt that, it's not really me, that the drug is not worth it from a cost effectiveness perspective, we don't approve the funding of it. We can approve it for safety and efficacy, but not the funding of it. And in those cases, you may be lucky enough to have a private plan that will pick up the slack, although that's actually quite rare, or you have to pay for it out of your pocket. And in many of those cases, it's impossible to do so. There is a program for these sort of orphan problems of very small populations with very expensive treatment that you can apply for, but again, it's quite difficult. And that's a relatively small number, by definition, that's a relatively small number of people. That's why they're called these orphan drug programs. But the bigger issue is, what are we doing with the most expensive ones? And the answer is that we're not funding those, or at least not right away. But that's not atypical. That's a problem that I think a lot of countries are facing. Yeah.
Thank you. Hi. Two trends that are pretty big here in the U.S., and I was wondering if they're on the rise in Canada, is telemedicine for one, and I would think that might help with wait times because we want everything now. So telemedicine, I think, is a good piece there. So wondering if that is an option in Canada. And then also the rise of electronic medical records, wondering if that's also a mandate there.
Yeah, so those are both interesting sources of controversy in Canada. So Canada is enormous, right? So it's a humongous amount of space of which almost everybody is cluttered as close as they can be to the US border, right? So mostly, we do love you, but that's not the only reason. It's because it's warmer down there, right? It's not warm enough, but it's warmer, right? And so there are populations that are scattered in this huge landmass where it's very difficult to get access, and it's very difficult to convince new doctors to go up there. And telemedicine is one of the ways we are trying to tackle that problem, and it has had some success, right? It's a huge issue when the closest hospital is about 18 hours away. We have to find solutions, and telemedicine is a solution that is proving somewhat successful. Electronic medical records are a complete disaster in Canada. We have, actually very much like the whole sectoral problem in Canada, we were very slow to get off the mark, we were very slow to agree on a system that would work between hospitals and doctors and between provinces. Nobody could agree. We had task forces that were trying to get this, and by the time we kind of figured things out, we're finally landing on a very expensive system that is completely outdated already, right? I mean, if you ask doctors saying, you're telling me I have to have a standalone PC now to access this, I can't do it on my tablet or my phone, and we're still struggling to get the standalone PC version going. Once again, we missed the boat. We missed the boat. And here, I don't think there's anything systemic about. It was just something that we messed up, and we're trying to fix it, but it has been difficult getting that agreement between. I'm always amazed when I go to other countries, and it's just so easy to have that. This is one of the challenges of federalism, right? That the provinces have every right to disagree, and some like to pull their weight and say, we'll do it our way or we won't do it. And increasingly, as the federal government has less and less skin in the game, right? They're paying less and less of the cost. Threats from the federal government that we're going to pull back money if you don't do what we say are met with, you don't pay anything anyways, what do we care, right? And it's almost a threat, right? To say, yeah, pull your money out, right? And so we've had a hard time coordinating.
Will you go into drug pricing, because not the super duper expensive drugs, but just Gordon Ratty stuff? At least the conventional wisdom here in the States is that if we can buy our drugs in Canada, the same drug will cost us less. Yeah.
If we could buy all of our drugs in countries that have lower prices, then the drugs would cost us less. But the drug so you're right. Okay, I'm going to say something slightly controversial, that those lower drug prices would not exist without you. Because without the United States paying these high costs, all of us countries that have low costs would have higher costs. right? That's a reality that I think people are unwilling to say out loud often. Now, that's not the same. There are cases when you want to think about generic brand use and how quick countries are to adopt generic or reference-based. All that, Canada is doing a relatively decent job at, and more recently, we're getting the price of generics down. But when it comes to brand name drugs, we are benefiting from the fact that drug makers are more likely to strike a deal for better prices with countries if they know they're making money off other countries who are paying higher prices, right?
Your government is actually negotiating with them, whereas we don't do that.
Yes, the provinces will negotiate, right? And they have some, interestingly, they have some, even though they don't have a public drug plan for everybody, there's enough people, like the elderly, for example, who do get public drug plans, there's enough people in there that they have some strong negotiating power, right? But again, right, I mean, you can imagine that drug companies are willing to cut deals by taking a look at their entire bottom line and saying the marginal benefit to us of cutting this deal is positive, so we'll do it, and we're going to have more money from someplace else, often here, right? But if you were to be buying from us, those deals would be harder to strike. That's
Actually, Medicare D, I think it specifically says the government cannot bargain with
yeah.
drug companies. So if that was, that's
Yeah.
conventional wisdom here. So if we change that, you're basically saying that we might pay less, but you pay more?
I think that there is no way that if Medicare, US Medicare, started bargaining with drug companies, you would not be able to get a better price. I mean, I could be wrong, but that seems hard for me to understand how you, with that kind of buying power, how you would not be able to extract something there. I'm not an insider on Medicare Part D, but if I had to take a wild guess as to why that clause is there, is to protect the drug industry and not to extract the best price. Now, the second part of that is, would you then see prices elsewhere go up? I mean, I'm speculating, but my speculative answer would be yes, because they have to think about their entire return, and if they're losing here, how are they going to make up for it? Pick a small market and try to get those drug prices a little bit higher in those markets. Or, I mean, I don't know. It depends on their revenue function, but you could imagine that being the case. I could be mistaken. Maybe my colleagues will correct me afterwards, but I don't think that's inconceivable. Yeah. So please don't. Yeah.
Thank you. So there are two aspects of your talk that I noticed. So number one, you said that one of the principles is that if you're a resident of a province, you could go to another province and still get coverage. The second part is that you mentioned there's huge disparities in what technologies or, for example, immunotherapy drugs for cancers that different provinces cover. Does that lead to kind of a quote-unquote freeloader issue of people moving in between provinces to try to get the best health care that they can?
So there are big discrepancies in outcomes. The discrepancies in what provinces cover are there. I wouldn't call them huge, but they're definitely there. And for a particular drug, they can be super important. So in order to, so there's portability and then there's portability. If you're just driving along and you've changed provinces and you have a problem and you've got to go see the doctor, it should be smooth, right? They'll accept the fact that you're a Canadian or a Canadian resident and have coverage in Ontario, even though you happen to be in Quebec that day and need care. Something a little bit different is, can you, for a long-term treatment, just go back and forth, right? And that is a little bit harder, because in that case, you should define a province as the province of residence where you pay taxes and where you can do that, right? And certainly there is movement within Canada, as there is here, to places where there is, but it's not just about the healthcare, right? It's about healthcare, jobs, et cetera, housing costs, the whole package of livability, right? And there has been a constant flow migration from the poorer places to the richer places, much to the despair of the of the culture of those poorer places, right? But that happens, for sure. And there's nothing to stop that at all. But it would not be the case, or it should not be the case, I'm not saying it isn't the case, but it should not be the case that you can, over the course of several months each day, go and get your care in the province that offers something and then have the province you live in pay for it. Right. You'd have to declare residency and pay your taxes there. Yeah, I'm following the mics. But.
So thank you. You talked about one of the 4 criteria in the beginning of pooling risk. And you mentioned that with income inequality, the richer people, as they get richer and richer, don't want to share in that risk. One of the things I think we've seen with the Affordable Care Act is that younger people have to share in that risk because, you know, it's the older people who tend to demand more from health care. And I've begun to appreciate that more and more as I've gotten older. But we also in the U.S. have a system where you can either have an approved insurance plan or you can pay a fine, basically, to opt out. And what we've seen is that young people have decided that they don't want to pool their risk. They opt to pay the fine. So how do we deal with this issue of universally pooling risk if we've got rich people and young people that don't want to be in the swimming pool with us?
Yeah. To my mind, this is the sad part of Obamacare, right? The recognized need that risk needs to be pooled and the failure to put in place a system that effectively pools it. So you don't need to have a single payer system like ours or like the NHS to pool risk, but you do need to have a pretty strict mandate, right? In fact, you have to get people in one way or another. And in lots of countries where you can choose between a variety of insurances offerings, there is still, for the vast majority of people, a requirement that you choose, right? That you can't just opt out and pay the fine. Now, I understand, having studied this a little bit, that decision to end up where you are was complicated. It included a lot of negotiation, included some court trials, it included lots of stuff and I'm quite confident, because my advisor was one of the people who worked with the president to help build this system, that they knew very well that this was problematic, right? But nevertheless, I mean, this is a huge problem, right? And frankly, what happened with the most recent tax changes here, where we included some relaxation of the mandate, right, is going to have in my view, severe consequences for Obamacare and pooling going forward, right? That in fact, this is the most intelligent way to kill Obamacare I could have thought of, which is you don't take away the subsidies necessarily, you don't take away the pre-existing condition clauses, so all those people who really wanted to be part of that don't feel you take anything away from them, but you do take away the mandate, and all the people who didn't want to buy now are not being forced to buy. It's the most effective way to undermine Obamacare that I could have thought of, right? Where you don't piss anybody else, you don't piss anybody off, but you do exactly what you want to do. And I think that's really problematic, right? You got to find a way to pool risk, and that includes getting the young people in the system.
Hi, thank you. As Peggy already mentioned, there's interest in social determinants, social drivers here in the U.S., and interest in integrating with healthcare. It's trending upward, but it's still at low levels. And you'd mentioned, social spending and education; these types of things have dropped in Canada. How much has integration occurred in Canada and trying to tie health and healthcare and social programs together?
We suffer from the same problem that most countries suffer from, which is this is a very siloed thing, right? That there is a health budget. That health budget, because of the demands on the system, much like Anita said, is very focused on health care. There is a budget for other types of social care, and it is much smaller, and it's led by a different department. And yes, those departments talk, but the number of issues that the Minister of Health has to deal with are so, with regards to the insurance part of the system and dealing with doctors and hospitals, are so overwhelming, and that there's very little attention paid by that department to the social issues. That said, just like everywhere else, there's an increasing recognition that other part is huge, hugely important. And there is the same debate that we're seeing in a lot of other places around providing income supports, providing education supports, providing the proper support for people to improve their lives and therefore reduce their healthcare costs. But this is long-term. This is long-term, right? So it's not that integrated. So the answer is it's not that integrated. It's not being ignored. It is being done. More debates are happening around should we have more, something like a basic income, should we have increased, a variety of things are being debated. And the payoff for those things is going to be many years in the future, even though they have to deal with healthcare concerns now.
Do you have data on inequality of access of the wait times, and
Yep.
is there inequality in wait
there's some
times
data. There's some data. I mean, as you might expect, or maybe don't expect, but so when you use price to ration, it's clear who gets access, people who can pay. When you use wait times to ration, you would think that it would be more need, but in fact, there is a huge discrepancy between where you live and who you know. And these things are huge drivers of how fast you'll get care. If you live in downtown Toronto, your wait time for something will be much shorter than if you live in almost anywhere else, because we have lots of hospitals, we have a lot of wealthy people hanging out together, and access happens, right? It's not rationed by price, but it happens nonetheless. And so there are inequalities, huge inequalities, well, big inequalities, and it's hard to figure out what to do about that, because you're just going to have some zones that are intensive in their healthcare industries where there's going to be more supply, where it's easier for you to get a phone call saying, we have an opening this morning in 2 hours, can you be there? Oh, when you live 10 minutes away, yes, you can. All right, when you live 6 hours away, you can't. Right? And so you tend to see that inequality happen. What to do about it is a different story.
Do you have the same issues with respect to a lack of healthcare workers or a shortage of healthcare workers and discrepancy between the specialists and the GPs? And also, what about capital expenditures and technology?
So we've had ups and downs in healthcare workers' access, so it is a policy design of how many healthcare workers to train, not train, and we've had expansions to try and deal with predicted shortages. We've had so Canada has a policy of selected immigration, where you get in faster if you are high education, like something like being a physician. That doesn't mean you get to practice, because the physician board has to approve that you practice, and there's lots of reasons why they might not all of them good ones. But in this exact moment, I would not say that shortage of professionals is Canada's big problem. Similarly, with capital expenses, we've seen ebbs and flows. We just went through a period of a lot of spending. And we are now seeing some of the backlash to that with governments who are being elected who want to put the brakes on that. And so, again, I would not say capital expenditures are an issue right now, but we may see more of that. You do see this sort of cycle happening over the last 30 years. And I think now we're on the more generous part of that cycle, right? More debt, more spending, but there are still wait time problems. And there, as I said, there's a coordination problem. There's a lot of stuff getting done that maybe shouldn't get done. And there's some areas where we just need to spend more. And that remains.
Thank you so much for this excellent talk and the questions. We'll have a 15 minutes break now. And so thank you so much.
Thank you.